So I wanted to let you know about some of the work that we're doing, but most importantly, I suppose, some of the kind of ethos that we're coming to this with, and the understanding about how the digital revolution, or the digital kind of shift is coming in healthcare, which is completely inevitable, but some of our thoughts about why that's going to happen. So what we are is a digital health company. We're 2.5 years old, based down in London, and we're really focusing on building a clinically led patient engagement and self-management platform. And what we think is the key, obviously, is to focus on improving outcomes and reducing costs. But that's best done when, as a technology company, you try to not think about technology as much as possible. So any great technology works when you first of all consider people, behaviours and relationships. That's why actually things like LinkedIn, Twitter and Facebook are so good and compelling and get so many people using them, because it's not about the lines of code, it's about the people that are interacting with that platform in a more effective way, and something that replicates or digitizes something that's fundamental to what we're all doing anyway. So our take on it is, how can we try and focus more and more on what people and patients are doing for themselves and improve how they're managing their conditions, and facilitate or improve the relationship that people have with their clinicians. So enhancing that process of shared decision making, and then put a bit of technology in the mix to hopefully make that better, quicker, efficient, more efficient, and then quite scalable so we can get out to more people. So our take is try and focus on improving those relationships between people and strengthening that through technology. And digital health isn't going to happen because of a free downloaded app that has some big data analytics behind it, because healthcare is delivered in context, isn't it? And it is about sort of people and relationships. So that's very much our approach, and I think it's something that we think is really important, that's focused on in this area. Clearly, as well, it's important to focus on evidence and showing the impact of what you do. And that's some of the early work that we're trying to do as well. So we say that we're design, evidence and clinically led, and that's reflected in our team makeup. I'm a former civil servant and have done public service delivery. Ben, my co-founder, is a designer and a programmer. And critically, the third sort of pillar of the company is Rashmi, who's a psychiatrist and has a master's in public health. So having that clinical leadership in the team, I think, makes a critical difference when you're thinking about every decision on how you're going to build the product and how you deploy it. Having a doctor there in the team thinking, well, actually, no, don't do that, or change this, and linking it back to clinical pathways is essential. So where we are now, and then I can show you some screenshots of the app, and then I can demo it to anybody that wants to have a play later as well. So we're currently deploying mostly in the UK, and we've just secured our first contracts in the US and Australia, which is exciting. Just some things of note, and I'll tell you more about the work that the AHSN is supporting later. But we're doing some interesting work in Parkinson's disease. So down the left-hand side, you can see 6 centres. There's also King's College. So we're running a proper randomised control trial, including in the Walton Centre. This is old stomping ground. We've had over 210 patients recruited onto a trial across those 7 centres, ethics approved, adopted by the Clinical Research Network, and looking at how this technology helps people to improve medication adherence in between 16 weeks appointments. And then when they come back to see their clinicians after 16 weeks, how does the data collected translate into an improved shared decision-making experience? And we're during the trial now, so we obviously don't know what the results are, but indications and feedback from clinicians and patients, really exciting about how they're saying on the patient side that they're understanding themselves better. A lady in now this is when I sound a bit like a politician, isn't it? That every politician always has a story about when just the other day they spoke to someone who said this. So forgive me for that. But we were speaking to one of the participants in Liverpool, and she said for the first time her husband in 6 years understands her medication regime, because she can see it in the platform, in the app, and it's kind of stepping her through things. So really nice feedback about how it really supports people. And then a lot of feedback, particularly from one of the clinicians in Newcastle, about how when his patients are coming back after 16 weeks, they have a more fruitful conversation that helps make better decisions about the next period of care as well. So Parkinson's, we're doing a lot of work in. You can see some of the other areas. oncology, diabetes. I think mental health is going to be a huge area. It's good to see Big White Wall on later, who we hope to be able to do more and more work with in the future. But I think mental health is a huge area of sort of wide open space, in a sense, for digital health, where people have, it's terrible the lack of provision for people now, and how digital technology can really get out and help people in a way that makes a real difference in those areas. So we've got, just in the last couple of months, the first 3 projects secured. One in Tourette's, which is quite interesting, one in self-harm and suicide prevention for young adults, and another one in a kind of an adult mental health context. So we're in 12 conditions at the moment, mostly in secondary care, but moving into primary care, public sector, and then increasingly private sector as well. I just thought I'd note our first US deployment is in cardiology at the Brigham Women's Hospital in Boston. And I think, no doubt, thanks to the work that we're doing at the Liverpool Heart and Chest, that played a critical role in us being able to secure that contract. So thanks for the help there. So a bit about what we're doing. I can talk to any of you a bit more about how the platform that we've got configures and how is it that we're able to use the same app, the same technology in all these different areas. Well, part of it is focusing on design, focusing on the understanding about people, patients, whether you're managing a long-term condition or post-operative care. Often they need to do the same things. Need to track some symptoms, track some things about how you're doing, often record your medications and how you're doing on various tasks, record a diary, and communicate better with a clinician. Now there's some fundamental things that are fairly similar processes or transactions that need to happen across all of the different conditions. And then on the clinician side, clinicians often want to provide their patients with engaging material to get them interested and doing more themselves. And then that can be tailored and personalised in each of the different clinical conditions. So a little bit more technical here, so I thought bear with me a little bit, just so you get kind of the shape of what we do. On the left-hand side for people, patients, there's an app which is live on the App Store and the Android Google Play Store, free download for patients, and a website. And when people log in and create their account, they have a unique code that assigns them to a particular database. Our logo in the center there is the database, and it's a different database for each of the 30 or 40 deployments we have, which is great because the database tells the app how to set itself up. It's a bit like a Lego kit with different blocks, and the database tells you which set of instructions to use. On the right-hand side, clinicians have a website, a web portal, and that looks at their specific database. So in our Parkinson's trial, 7 different databases, and it means people at the Walton Centre don't see the people down at Adam Brooks in Cambridge. So this is part of how we're level 2 information governance cleared. And we bring in data from external wearables and external devices, and increasingly with other systems and solutions. So great systems like Patients Know Best, and we've also done an integration with Microsoft HealthVault. And over time, the exciting thing is lots of us sort of fairly small startup businesses, we're doing all of the linking up anyway. So it's not like you need to wait for sort of big lumbering IT businesses to do stuff. I think a lot of people are doing the link up, which is really quite exciting. And there's so much more that's already there that can be deployed that we're doing, Big White Wall, Doctor, PKB and others, which is quite an exciting future. But based around people owning their own data and the data flowing where patients and clinicians want it and need it. So our take on everything we do is that people should own their own data, not us, it's not our health, it's their health. And that data should be theirs to take, maybe they'll use our app, our platform for a while, maybe in 2 or 3 years' time, that needs to go somewhere else. And that's got to be the ethos and it's got to be the approach. As things join up, the data needs to flow with the patient and not be locked away in silos. So just a couple of screenshots and then I'll tell you a bit specifically about the work we're doing here. This is some of the screens on our app. The nice interface that sort of sets us apart is on my phone, which is over there. Can I just grab that? I'll do it quick. Sort of demo. Is the screen on the left-hand side, which is uMotif. Now, you'll be forgiven for thinking it looks like a flower. Now, really importantly, Ben, my co-founder, is a designer, and you know how designers can get a bit sniffy sometimes. He's designed a motif and not a flower. So if you ever meet Ben, don't call it a flower, but he's not here, so it is a flower, basically. And each of the petals, or I should call them segments, represent an aspect of daily life relevant to that condition and that patient. So the example I've got here, and I can do a bit more of a close-up demo, is set up for Parkinson's disease, and people swipe their finger in and out to give themselves a score, maybe once or maybe multiple times per day, on various aspects of daily life. Now, this is where it's clinically led, because we work with the clinicians to decide what are the relevant segments in heart failure or oncology or Parkinson's disease or mental health, and we put those into the app. So it's a completely tailored personal version for each of our clients. So the Brigham and Women's Hospital in Boston will have a different set of segments than Liverpool Heart and Chest, for example. And this is a really nice way of getting clinically useful, not clinically validated, but clinically useful information captured by the patient that engages me, but provides the clinician with some really good indicative knowledge about how people are doing. It's not quite your kind of validated survey questionnaire. We can ask those as well, but something quite engaging for patients. We bring that data back alongside other biomedical data, deliver content for people, and it's the combination, we think, of data from sensors and devices combined with data about how I feel I'm doing. Because most patients feedback that they don't feel that just a weighing scales or a blood pressure monitor quite gives the roundness of how they're doing. It's often that subjective feeling, which is quite important. The data flows back to a website, and the patient and clinician has a portal. They see basically the same thing. And we've got some neat ways that we provide insight to that relationship, to the shared decision-making conversation, rather than deluging everyone with data. Because a clinician, within 7 or 10 minutes doesn't have time to log in, certainly doesn't have time to do 15 clicks to find the information they want. So we've found a way to surface that information, and as soon as I come in to see you, the data's there, and it's the data that you want to see already. So hopefully, really focusing on workflow and minimising that overhead on the clinician side. I thought there's plenty more that I can show you about the technology if you want to afterwards. I thought I'd just sort of maybe finish by touching on some of the work we're doing here. So again, thanks to the AHSN. We're working at the Liverpool Heart and Chest. We've set 2 versions up, one for a heart failure pathway and the other for a cardiac rehab pathway. And what they're tracking there in that motif interface are things like breathlessness, dizziness and swelling. So quite clinically relevant indicators that can also be compared and combined with weight measurements if people have scales at home as well. They're also looking at the importance of medication adherence, so people setting up a set of daily reminders, having the reminders, and then being able to check off what they've taken or not. So over time, the view here is that perhaps rather than there needing to be the nurse, the admin assistant looking at the data on the back end, over time, could there be a bit more learning that the system and the patient does to be able to see, well, actually, if I take my medications, I do my exercises, my breathlessness goes down. And obviously, the hope here is better treatment outcomes and reduced readmissions within 30 days. At the Lancashire Teaching Hospital, we're working with a consultant in oncology, and we've set up, again, two slightly different versions, so 2 slightly different motifs. One is for people who are recovering from thyroid cancer, the other is head and neck cancer, and the sort of things that they're being asked to track are different in each of those pathways because people experience different types of symptoms. So swallowing, pain and secretions is useful for the clinician and the clinical team to know. At Lancashire Teaching Hospital, they're using this across a number of different teams. So there's the consultants, there are the dietitians, there are the physios, and I think 1 or 2 other teams. And they're all being able to have a look at the different things that are relevant to their patients. And then upload content into the app, which to date has just been a sort of a hard copy leaflet at best. So you know how it is at the moment, sometimes when patients get discharged, there's not that much that they take with them. I think using digital platforms to provide something that's quite tailored to that clinical pathway is very useful, and that's what we're seeing at Lancashire. I hope that's given you a run through, and I haven't gone over too much time. The technology's in place, and we're demonstrating some interesting early stage successes, but our view is that the shift is definitely coming, where people will increasingly expect a digital journey. And I think within a couple of short years, it will be seen as fairly unacceptable or unbelievable that in 2015, I'm probably going to have a knee done in the next few weeks, that I'll be discharged from that, and that will be it, bye-bye. Maybe fill out my, my proms and prems in 3 or 4 months, but I'll probably have nothing. And I think within a couple of years' time, it will be known and expected that you should have a digital health journey in exactly the same way you expect to bank online, shop online, and book your flights online. It will become the de facto norm, but only because it's focused on patients and clinicians, and then the clear benefit that delivers, and that it doesn't have to be massively costly to put this into use. So that's us. I can take questions, and more than happy to do demos. And you do need a code to get in the app. So if anybody wants a code, my email address is there, and we have a few demo versions. So just drop me an email and we can get you set up.
I can take one question.